Testing. Okay, good morning. I am Raul Garza, and I am just the acting chair for this committee today, filling in for my colleague, Director Bott, or Chair Bott. I'd like to call the meeting to order and ask that the secretary takes roll of attendance, please.
So we have two substitute members today. Director Masood Barnett here, and Acting Chair Garza is also serving as a substitute.
Present.
And Director Kim? Present. And I believe we have Director Webster Cross remotely attending. Director Webster Cross, are you present?
Present. Thank you.
Thank you. And further calling the roll call, Director Sorrell is absent, Director Staines is absent, and Chair Bott is absent. You do have a quorum.
Thank you, and thanks for filling in, Gina. Appreciate that. Let's see, the next regular meeting of QPS will be Friday, December 12th at 9 a.m. I'd like to ask for a motion to allow Director Mia Webster Cross to participate remotely in this meeting as a voting member. Do I have a motion, please?
So moved.
Thank you. I need a second. Thank you. I have a first and second. Is there any discussion about that? Okay. All those in favor, say aye. Aye.
Aye.
All those opposed? Okay, that motion carries. Madam Secretary, are there any speakers registered to provide virtual or in-person testimony, or have they sent in written testimony, written testimony to be included into the record?
We did not receive any registrations nor any written testimony.
Okay. Item number 3, 3A, appointments, reappointments of the Stroger Department and Division Chairs. I see that none are being presented. Is that still the case?
That's correct.
Okay, thank you. Move right along to item 3B, Executive Medical Staff, EMS of Stroger Hospital, and the Medical Executive Committee of Providence Hospital, reports and action items presented by Dr. Thomas Patrianicos, EMS President, and Dr. Paul Allegretti, MEC President.
I do not see Dr. Patrianakos present. Anyone from Stroger EMS? Okay. The proposed medical staff appointments, reappointments, changes from Stroger Hospital were sent in advance.
Got it.
So they are presented for your consideration. Dr. Allegretti is here, though, so would you like to come up, Dr. Allegretti? Dr. Allegretti, are you ready? Dr. Patrianakos is not here, so if you'd like to present your items. Yes.
Thank you.
Good morning, everyone.
Good morning.
Everybody received the document regarding the appointments and reappointments for Providence Hospital. This was approved by the Centralized Credentialing Committee on October 23rd, and also approved by MedExec at Providence on November 7th. And I'm here to ask your approval, and if you have any questions or comments.
Okay, thank you. I'm asking for a motion to approve item 3B, the proposed Stroger Hospital and Providence Hospital medical staff appointments, reappointments.
So moved.
Is there a second?
Second.
Thank you. We have a first and second. Is there any discussion? Okay, all those in favor, say aye.
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 All those opposed? Motion carries. Thank you. We'll move to item 3C, minutes of the October 17, 2025 QPS Committee Meeting. I'll present those. I will remind everyone, though, that those were approved by the board at the October meeting. And, I'll ask if there are any corrections needed, as soon as I ask for the motion. So I'm looking for a motion to accept item 3C, the Quality and Patient Safety Committee meeting minutes of October 17th, 2025. Do I have a motion, please?
So moved.
Thank you. Second?
Second.
Thank you. Are there any corrections that need to be made or discussion? Okay, hearing none. All those in favor?
Aye.
All those opposed? Okay, that motion carries. Moving down to item 4A, Operational Excellence Dashboard Goals and Tactics. Reviewed by, the first one to review will be Raji Thomas, reviewing Stroger Hospital's site review.
Good morning, Chair.
Good morning.
Good morning, Director. Debbie, can we go to the next slide? Next one, please. All right, I am presenting Stroger OPEX Committee Dashboard on behalf of Danke, Chief of Health Executive for Stroger. Under the patient experience domain, first metric, which is the top of communication with physician, that has been trending really good for both monthly goals as well as our rolling 12-month metrics. As you can see, the rolling 12-month data has been really trending above our target goal of 85, and monthly also has been performing well, but as you see, there was a little dip in September for both, a physician communication domain and nursing domain, which we are looking into. Moving on to communication with nursing domain, the rolling 12-month data has been performing above our stretch goals, as indicated by the purple color there, which is really great. That was a metric that the team had been struggling with for a long time. So kudos to nursing leadership and Stroger leadership for bringing those numbers up. Looking at the monthly numbers for the same metric, as you can see, we've been performing above our stretch goal as well, except for September. As I indicated, we will look further into, the performance that month to see if we can define any specific reason as to why we saw a dip. Moving on to the next domain, clinical outcomes. The mortality index, as you can see there, we've been doing pretty good. However, I want to refresh with the board's memory that this is a process we started in 2025. So this year, our goal was to establish a baseline before we start, monitoring this metric more aggressively. But so far, with the processes we put in place and the subgroups, work groups that we have, identified to look into mortality reviews of, certain cases, we are pretty confident that by 2026 we will be able to show the board more, better results, showing that we are making a difference in how we are tackling the issue. As we have mentioned in the past, most of our issues are related to documentation. So there is going to be a lot of focus on clinical documentation improvement under Dr. McCormick's guidance next year in 2026. We are in conversations with various stakeholders to address that. Moving down for PSI 9.
Raj, I have a question. When you say the challenge is documentation, but can you go a little deeper on that? Exactly what does that mean?
Correct. So, under the mortality index, we are looking at observed versus expected of, cases, mortality cases,
Right.
death rates of certain patient populations. However, what we are identifying is that in how we code these cases and how we identify, the reason for admission or, certain, treatment options, we, identify for the patients. It's not always documented correctly or
Right.
fully.
So what causes that, I guess, is what I'm asking. I mean, what, is it a training issue? Is it?
It's multifactorial. Training definitely is an issue. We did not traditionally, historically had a very good team here looking at coding per se, of various, aspects of, it's not just related to mortality, but, it's applicable to other things, clinical outcome cases here. It also impacts our CMS scores as well. So, the CDI team was established just 2 years ago. So, and then last year or in 2025, we identified workflows that allow the multidisciplinary team to come together and review each of these cases and, correct coding issues, billing issues, and any data that goes out of our organization, in close to real time. I can say it's still real time. It's close to real time. So there is a lot of work that needs to happen, or other organizations take more seriously before any information related to coding of these cases are released to the public. So, Mikhail,
Sure. Yeah, and it's multifactorial, as Raji was saying. There is a training component, yes, of course. There, I think that always helps, but there's a process issue, especially as it pertains to PSIs, where how the admission gets coded. Is it an emergent? Is it elective? Is it right? So a lot of the PSIs get taken out if they're flagged as emergent admissions, right? So that has been work in that space as well as how we register the admission. And then on the back end, what kind of flows through coding from what's in the chart versus what might be missing, and that follow-up question back to the clinicians. That piece is something that we're working to put in place right now, so that our coding team is actually, coming back to say, hey, this looks like it might be sepsis. You didn't document it, or you documented sepsis. It's not actually sepsis. We're not seeing the criteria for that piece. That closed loop closure doesn't quite exist yet. And then similarly with sepsis, it's kind of a similar challenge that we've had. When we abstract the chart, we are able to look in various places like flow sheets, and we can discern that, yes, the right things were done when we've outsourced it. Now there's much more rigid about what is and is not allowed, where it has to be documented. And if it's not in those places, then they don't end up counting it, which is why kind of we saw that drop is right at the same time as we outsourced the review process. So
that process was implemented last year?
correct. We
Yep.
pulled a multidisciplinary team. We
Yep.
had a process, but that was very fragmented.
Yeah.
Quality being a
No, I'm
key
talking
to that
about the
process.
multidisciplinary team
Yes.
that was implemented last year.
Correct.
Got it, okay. Thank you.
All right, so PSI 90 composite, it is a composite measure that includes 11 measures. So it's a pretty big bucket of, clinical outcomes that we are looking at. Again, this was something we started focusing on in 2025. As you can see, we had some really strong performance, under this domain for the past several months. But, next year, this will continue to be our, one of our focus areas. Step one, bundle performance, as Dr. Mikhail mentioned. Again, the numbers you see there do have a clinical documentation element. So just to refresh the board's memory, one of our challenges that continues to affect our scoring and our performance with CMS and leapfrog is the documentation of blood culture collection timing. Since we updated the board last month, we've been focusing on two major things. We had a rapid improvement event to identify opportunities with the processes that was led by our process improvement department, which involved pulling all the stakeholders in ED to see where there are, challenges or barriers with, collecting and documenting the blood cultures in a timely manner. We are also looking to leverage technology we currently use to ensure that the time of the blood culture collection is accurately reflected in the patient's chart. So right now it's a manual process. So nursing would document the date and time on the specimen collected, and lab then manually enters that information in the chart. In a lot of cases, I wouldn't say that's the case in every situation, but it happens a lot, which does impact, as you can see, since it's a manual process, there is variability in ensuring correct information is documented. So the team is working to upgrade our current technology that lab uses and also we are adding additional handheld devices, scanners, that will allow nursing and phlebotomists to scan the specimens at bedside, which will then translate into patient's medical record.
I think I heard about that a couple of months ago, I remember. So how far are you actually implementing that?
Our timeline, our estimated time of completion of that project is February, but we are hoping to get that done even sooner. There are no challenges we have identified so far with obtaining the devices or training or, implementing any part of that project implementation. However, in the meantime, while we are waiting for technology to be onboarded, we are also meeting with our staff, as I indicated. Like one of the focus areas of that rapid improvement event was to see if we could strengthen the workflow we currently have to improve, the documentation element of, specimen collection. So we have an interim process we are working on that involves people, technology, and workflows, structures, culture, all those elements while we wait for technology, new technology, better technology to be brought.
What's the timeline on that, on the technology being brought up?
February, but, project team just told us it might be even sooner.
Great, thank you.
All right, Debbie, we will move on to the next slide. So under readmissions, COPD readmission rate, as you can see on the screen, it's been trending above our stretch goal, which we are very proud of. However, when we presented this data a couple months ago, board was interested in knowing why we had a dip in performance after some really good, strong performance over several months prior to that. So looking further into those cases, we identified that we had a handful of patients who were readmitted multiple times during this time. That really did impact our data there. And again, as we dug deeper into the data, we realized that the issue was not really related to, the care itself or the reason for admission, but documentation, correct documentation of the reason for readmission. 2 out of these 6 patients, or 4 out of 6 patients were readmitted for reasons other than COPD management related concerns. So again, it goes back to our earlier point about strengthening our processes around, clinical documentation and having, better auditing processes, built within those processes to ensure that correct data is collected and reported. All right, moving on. Post hospital appointment days for adult pulmonary care. We've been performing above our stretch goal for the entire 12-month time frame here. So that metric, that group is doing an amazing job there. Moving right along, under the throughput domain, for 12-month geometric mean length of stay, as you can see, we have reached our target for the past several months, and rolling 12 months also seems to be, significantly positively affected by our strong monthly performance. Moving along, median length of stay for ED patients, we've been doing very well for the past several months. However, you might notice a little dip during June and July timeframe. As we looked further into that data, we strongly believe it has to do with onboarding of our new residents. That's something we will keep in mind as we, for future, resident cohorts joining us, so we can be more proactive. That's the end of my report.
Thank you, Raji. Any questions? Okay, thank you. We'll welcome Dr. Arnold Turner to present the Provident Hospital site review.
Good morning, Chair.
Good morning.
Good morning, Director. Good morning. Provident has 6 key areas of focus. You can see on the summary slide there. One of the areas of meeting stretch goals. 3 are meeting the target goal. 1 is better than the baseline, and we have 1 that's not meeting the target, nor is it better than baseline. Next slide, please. First one is the one that's not meeting the target, nor is it better than baseline. And that's the patient surveys. We put a lot of effort into this. Still have not been able to be successful. Return volumes are still low, but they're continuing to be historically updated. Despite that, we're still not meeting the goal, and we will not meet it for this year. Like I said, we did put a lot of work into this as far as when we discharge the patient. Both with hospitalists and nurses talk to the patients about completing the survey. When they get the calls the next day for follow-up, they're asked to complete the survey. And in the discharge photo, we put a flyer specifically addressing the survey, and still have not been able to budge. The volume is still extremely low. We really want to increase that because we really want to know what our patients feel about our service. That's the only way we can include them in our planning if we hear from them. So we'll continue to work on that. The next one.
Hold on a second, Dr. Turner. Sorry, the print's very small. What is the completion rate on the surveys?
It varies from month to month. I mean,
Just the average for the year.
I think this year the average has been around 15.
15%?
Yeah.
Yeah. And so is there any...
15 returns, not percent, 15 returns.
Okay. What, any use of technology in there, like text messages or anything like that?
There's some restrictions as far as how we can collect this data.
Yeah.
Right now it's mail surveys. We plan to move to emails in the near future, but right now
Well,
we can't.
I'm saying a text reminder, not something that prompts them, not something that takes them into putting personal health information on in the text. Yeah.
CMS for the first time allowed us to start using electronic surveys in 2025. So the team is in the process of implementing, technology that would support us with collecting the surveys. But the team is experiencing some challenges. It's not fully implemented, but we are not, from what I understand, we are not an outlier with, implementing those survey techniques. Our colleagues in the IMC area also are experiencing challenges. So we will continue to work on that because we want to explore technology-supported survey collection.
Thank you. Go ahead.
Do you use patient portals for the survey?
There are restrictions, as Mr. Turner was saying. CMS does not allow us to influence the patients in any way to increase the survey response rate. So we don't currently use patient portal for survey collection. We depend heavily on mailed out surveys. But the challenge, as Dr. Turner said, is we have a high returned survey volume here. Like the mail that we send out comes back to us undelivered. That significantly affects our ability to collect those numbers. And the other challenge that we see across both Georgia and Providence campuses is not having the correct information. So they've been working really hard to communicate with the patients. The reason for getting the correct demographic information, they often think that it's for billing purposes, but they have those conversations while the patient is in the hospital, letting them know they will be getting a survey. It comes from Katy, it doesn't come from county. So there is a lot of education that goes into all of this before the patient is discharged.
I don't think I understand why there's limitations, using patient portal, because, I've seen even like surveys from researchers going through patient portal.
Yeah, it's actually mandated through CMS that there's a certain way that you can survey for them for it to count, so that we delegate that out to Press King, and that's through how the surveys are sent. Now, the e-survey could be done through that way, but it's not actually tied through the patient's portal like their EMR. They're kept separate, and it's unfortunately just the way it's set up.
Wait, so this is a patient satisfaction survey. Yeah. And, so I'm with, Director Kim. I'm having a hard time understanding it. And this is personal experience, both as a patient and in my day job, but, I think our completion rate is much higher, probably around 30-something%. And it's done it is tied to the medical record. So the medical record generates the survey, and then we get the results back. And I'm wondering why we wouldn't be restricted unless we're out of compliance. And then I've got calls to make on how they get that. Okay.
The CMS HCAP survey cannot be delivered to patients through the patient portal.
Yeah.
It can now go via email, though.
Got it.
You could potentially send other satisfaction surveys
Got it.
that are not
But the
official.
specific CMS HCAP has restrictions on it.
Correct.
Sorry. Okay. I'm sure that was said.
Say for research, right? If it's like a research survey, that's totally separate from HCAPS.
Thank you for that clarification. Thank you.
Next area of focus is nursing communication. The rolling 12-month coming in at 81.66 percentile top box for November of 2024 through October 25. Our monthly score for October was 83.33% top box. Year to date, we are meeting the goal. Due to lower volumes, return monthly variability is expected. Quarters 2, 3, and 4 are meeting improvement expectations. This measure is likely to show yearly improvement to meet our expectations. With respect to sepsis, we still have very low cases that qualify for that, but our rolling 12-month compliance is at 54.17% top box. There was no data for September. We continue to see very low volume of cases that qualify for this measure. However, we do think it is possible for Providence to hit the target by year end. With respect to falls, we continue to do quite well with that. We are meeting the stretch goal this year. So far for linear trends at 12 falls for the year. We have had 2 consecutive months back to back without any fall occurrence. Very proud of that.
Yeah. Wait, will you remind me, Dr. Turner, I know this, I'm not sure how recent it was, maybe in the last couple of years, this was a major focus of improvement.
Yeah.
Yeah. How long ago was that?
That was last year.
Was it last year?
It was,
Student nursing focus
Yeah.
for the past 5 years or so, and the team has significantly brought down the patient falls, inpatient falls.
Yeah, I remember that.
At both Georgia and Providence campuses. So, Peter, could you tell me?
Good morning. Good morning. Yeah, patient falls and all the nurse sensitive indicators were a focus for the last 5 years, as you know, Dr. Thomas said, where we are reviewing 100% of all the occurrences. Then we engage the nurses, frontline staff, and understand the gap, and then they come together with an action plan. Now it's really to show that, the improvement. And we had to do a number of things, including changing some of the cards and things like that. So it's a system approach to improving quality.
Yeah, what was the peak number of falls, in that period of time?
You know, one time we had up to, I remember the day, you know, up to 35.
Wow.
And so then of that, 9 of them were connected to some device or
Yeah.
tether device, and so we addressed that. So we had a high numbers, especially in ED, and now it's
No, I asked the question because I wanted to direct the board to appreciate what Dr. Turner said, something like we should be very proud of, because that's a lot of dramatic change over a period of time.
yeah, it is part of, actually, truly it takes, it's part of everyone's daily life, right?
Yeah.
Everyone is engaged, so that's important when you do the rounds, the nurses, the physicians, we all talk about those indicators, so it's really helped.
Yeah, that's great. Thank you.
Thank you.
With last year, at the beginning of last year, Providence was at a little bit above 30 falls. It's really, really up and down.
Yeah, thank you.
And the nurses are very engaged, and they're very proud of the fact that they've been able to accomplish that. It's been a very much so a team effort. The next area of focus is the ED decision to admit to depart the ED. Meeting target for October 25 at 103 minutes. Year to date, we are meeting the stretch at 99 minutes each quarter. Quarter 1 through 4, we have met the expectation. We anticipate meeting this target for this year, and likely to improve to the stretch target. Next one is left without being seen, which we also continue to do quite well, meeting the target for the rolling 12 months of October through October of 2025 at 1.0%, very close to the stretch target of 1%. We were at 0.98% for the month of October, and we anticipate meeting the target for the rest throughout the remainder of this year. That concludes my report. Any questions?
Any questions for Dr. Turner or Raji? No questions. Thank you. And I have confidence that you'll improve that documentation challenge, because you've done it with falls, and I'm sure that the thought process is ingrained in, you know, how you work together as a culture, and then the whole process to strengthen the documentation. So thank you. At this point, I'll invite Craig Williams to provide us with the ACHN site review.
Good morning, Craig Williams, Chief Operating Officer. Here to report on our performance on ACHN around patient experience, HEDIS, and empanelment. For our patient experience scores, we're focused on 3 metrics. The first one being staff work together, which we know when we look at our overall scores, if we make progress in that metric, it'll drive our overall scores the most. And we've made gradual improvement this year, but we're consistently below target. We are better than baseline. We've actually grown almost 2 points better than baseline this year, and had a really good September and a little bit of dip in October, which I was surprised about. Around care provider addressing concerns, worries, we've seen gradual improvement. We've been consistently below target, but better than baseline. And you can see we sort of have sporadic variation from month to month, with some really strong months with some dips in between. It's sort of the same on that staff working together. We see that kind of sporadic, jumps and then lower scores. So it just kind of speaks to needing to always have always behaviors. And then the last one is provider explains problem condition. We've seen gradual improvement. We're meeting target with several months at or above stretch. In October, we met our stretch at 67.43, and year to date, we're meeting goal. Overall, on patient experience, we've put a lot of effort into it this year. I'm a little disappointed that we didn't move staff working together a little bit more, because it's been a real focus area for us. As a result, we pulled together a series of staff focus groups where we're bringing in staff. It's being led by Beth Bakovich and Claudia Burchinal, and really talking to the staff around what barriers they have in doing their jobs, how we could help them and clear hurdles, and really allow them to sort of be fully present for the patient. You know, I also think a big piece of this is that front desk first experience that we have with our registration staff. So we're putting some real effort into kind of retraining that staff and trying to win them over. We actually found some issues with one piece of work they have to do, which is around registration quality assurance. When we had these focus groups, one thing we heard loud and clear was they were doing a lot of work that was clearing edits, but wasn't actually coming off their list. And so they were really frustrated by that. So we're trying to put work to fix those things with the idea of trying to win back their hearts and minds and really put that back in front of the patient. So I'm confident that we'll make progress here, but, you know, it's been a little bit tough sledding this year. On HEDIS, really good. Hold on a second. Yep. Go ahead.
Can you
Oh,
speak to how that, how that's measured?
Sure. So it's the
Yeah.
same. We use Prestani. We
Okay.
send surveys, and those go out both mail and email.
Okay.
What we score here is the surveys that we receive back that month.
And that's from the patient?
It's directly from the patient.
Okay,
Yep.
so their perception
Yeah,
as to
absolutely.
how
Yep.
staff is working.
Yeah.
Okay.
I mean, ultimately, we also believe it's a metric of staff alignment and engagement, right? And so the more we can engage our staff, the better they're going to engage with patients.
Thank you.
Sure. Sorry. I was on a roll. HEDIS, really strong performance here on breast cancer screening. We're being stretchful, and we've met many MCO percentiles set by NCQA. We're doing really well on this measurement. I think there's been a real focus around breast cancer screening this year, obviously with Commissioner Lowry's birthday screening and just a lot of effort on that. On hypertension management, we've met the goal month to month, and we've consistently been above that measure. The last metric is empanelment. And I was surprised, you know, we were making really good progress throughout the year on empanelment. We had a goal of growing our empaneled members, which means patients that have been, are in our medical homes that have been seen within the last 2 years. So that's bringing new patients in and also making sure the patients don't fall off the back end. And we saw a little bit of a dip in the month of October. I will say we've been trying to grow by 3,000 members this year. We grew by about 2,000, so we have made progress. There's been a lot of focus on the team on this. You know, as I was thinking about that this morning, I think we really have to look at some of our new to established ratios to make sure that we're providing new patient access to our primary care physicians. And that's something I'll bring back to the team to talk about later on today. Any questions?
No questions? Okay, thank you.
Thank you.
Thank you both. So now we'll go through we'll go to item 4B, regulatory update, reviewed by Joseph Kapanis, the Director of Quality and Regulatory.
Good morning.
Good morning.
I wanted to just provide you with some regulatory updates. One I don't have on the list here, but it'd be important to include, from our CAP visit for lab at Providence. We did submit just the other week our corrective actions, so we're waiting on feedback for that. Let me run through this list of upcoming surveys for you. We have Illinois Department of Public Health outpatient dialysis here at Stroger. This is expected at any time. We're coming up in almost a year since we're expecting them. So again, at any time, and we're continuing to prep on that. We have Utilization Review Accreditation Commission for Pharmacy at Stroger. An update on this. Full accreditation was granted. The award is effective from October to October 25 to 28, so for 3 years. Also at Stroger, Illinois Department of Public Health EMS Resource Hospital Site Survey. We're thinking this may take place in early spring, and hopefully next month I can provide more information about that. We also have at CIRMAC, the National Commission on Correctional Healthcare for mental health accreditation. We plan to submit the application in late 2025 with the goal of a 2026 survey, and I expect that next month I may have more information on that. And lastly, as far as updates are upcoming, Cancer Registry team alerted us that they're planning to reapply for accreditation in March of 2026, and I'll have more information again next month. We have a meeting coming up on that shortly. At the bottom here, and this is really important, Joint Commission triennial prep for Provident has started. EOC rounds have been taking place now for a few months, and regulatory prep started in September and takes place on a weekly basis. As far as the previous triennial visit, it was December 5th through 8th of 2023. Again, triennial visit, it's anybody's guess since it's unannounced, but we're thinking maybe fall of 2026, but the plan is to be ready by this summer. So give you kind of an update with that. And I want to touch base a little bit, next slide please, on some changes that have taken place with Joint Commission for 2026, and again, go a little bit further into prep that's happening for Provident. So Joint Commission for 2026 has completely revamped a lot of their areas. They've titled it Accreditation 360. A lot of information on the slide. I'll try to just kind of keep it brief, but I want to hit on some high points. The changes for 2026 are streamlining and simplifying the Joint Commission process to better align with CMS's conditions of participation. That is the goal. And I hit on some high-level changes here, but these are some of the main ones. They're transitioning the Environment of Care, or EC, and Life Safety, LS chapters into one chapter called the Physical Environment chapter. So that's going to be a big change to those who have been familiar with those for quite a few years. They're changing the National Patient Safety Goals. They're being superseded by what's called National Performance Goals chapter. This is going to expand beyond just the safety goals to include both safety, quality care, and staffing. And we are waiting for approval, going to be rolling out, just like we did the previous year, a poster that's updated that will be on all surveyable units, as far as just a visual on the units that goes over these new 14 topics. And again, once it gets approved, you'll see that in some of the units, so that's coming up soon. They also have a big change here. A number of years they've used what's called the Survey Activity Guide. That is being changed and named to the Survey Process Guide, and it's been expanded to include a lot of different areas. It's basically a roadmap for accreditation survey. So I'm going through it right now, and it's a really, really good resource of expectations with all the changes of 2026. So this being said, what are we doing in Cook County as far as prep, specifically for Provident? And I want to run through a number of items here. So I created I called it a SharePoint site for CCH Accreditation 360. This includes all the new standards broken down by standard for the chapter leaders, who are the content experts in the chapters. It includes a crosswalk or disposition document of this, so that you can look at where the standards were in 2025 and where they may have transitioned to 2026. It does include the survey process guide I just mentioned before. I'm also including updated monthly perspectives, which is a periodical by the Joint Commission that gives you forecasting not only of future changes, but also talks about past challenge areas. It's a good resource. We are continuing, just I think another week or so, of what's called the breakfast briefing, so the breakfast learning series of all the changes that are coming in 2026. Started in September and is December. This is all online webinars and slides. That's another resource that people are attending. We did bring in through Teams last week a regulatory consultant to discuss.
And Joe, I'm sorry, can I go
Yes.
back to the breakfast learning series? How many, or what's participation look like? Are you able to tell?
As far as
how many people participate?
in the breakfast briefings?
Yeah.
Yeah, it seems to be a pretty good participation. What I've done is, since these, in years past, they used to be live, so now they're pre-recorded, so people can come in at any time. I blocked, during the weeks, typically on a Monday or Tuesday, 9 a.m. a time slot. But if somebody had something conflicting, there was a priority, they could go in on Wednesday or even a couple of weeks later and review not only the upcoming, the present ones, but the past ones. And they're available to next August, which is nice. So if I were to go in next June and say, you know what, I want to go over national performance goals and see, because I forget I want to hit on something, still available to us. So that's
the
nice.
flexibility to catch
Absolutely.
the session down the road.
Absolutely, yeah. So it's a good, that's a really good resource. And there's been some interesting challenges with that as far as some of their slides and their webinars. Again, I'm used to the live session, but it's still a very, very good resource, and hopefully people are taking advantage of it. It seems like a lot of people were signing in to at least review some of the slides. Yeah.
Thank you. Regulatory consultant.
Oh, I mentioned we brought in a regulatory consultant via Teams that went over a lot of the changes in 2026. She was a great resource, I think. It was a Q&A with that, but she'd worked at the Joint Commission in the past, and was able to provide, all the changes and updates. Again, areas where people could focus on, challenges we can expect. I think that was helpful as well. we're gonna be launching, weekly multidisciplinary team rounds. I'll start the week of December at Provident. Again, the plan is to have some chapter leads like infection control, medication management, for focuses. We can start working our way through the units and floors. We'll be doing that right up until survey time. And the takeaways with that will be, what are our challenge areas? What do we need to focus on? And ultimately, what we can quantify as far as trends. So that's coming up in just a couple weeks. In January, I'm going to start doing tracers, which is basically tracing patients through levels of care. So it's not just looking at the environment or doing the rounds we talked about. It's actually sitting down with staff. And again, use ED as an entry point. Patient comes through there and they transition to another level. I will start in the ED, work with staff, go through a chart, focus on specifically. We'll use medication management as an example, and pain or whatever it might be. And then I will then follow that patient like a survey would to the next level, or if there's multiple levels of care, working again with staff and looking for any type of holes in charting. And a lot of people don't think about this. Besides just finding deficiencies, it's also making, building familiarity and comfortability with staff as far as just getting used to somebody looking over their shoulder as they navigate through a chart, asking questions, and then kind of coaching them on not providing too much information. Because as a surveyor, you're sitting there taking your notes to put together a report, and 30 seconds can seem like 3 minutes of silence, and people sometimes fill that void. I want to coach them to not fill that and then go from there. So that's going to be hands-on. It's going to be really, really good. That starts in January, and that'll take place on a weekly basis as well. They create a weekly sweeps checklist, which I only share with a few people that will be rolling out, that I hope units will use as far as at Provident, and again, surveyable units. And that can be used or delegated out by unit managers or directors so that staff can then, self-police themselves as far as, in between when we're doing rounds. Things can change sometimes hourly or daily, and they can look at, again, what I like to call low-hanging fruits, which is a checklist you can kind of go down, and they can cherry pick or they can go through the whole thing. It's digestible, meaning it's about 50 items, so it's not 12 pages of stuff that just people get lost in. All the things that, the surveyor could find that, again, low-hanging fruit type things. And lastly, and we're still fleshing this up, we plan to do a mock survey linked up to the safety performance goal guide, take place over probably 2 days in either March or April. More to come in the monthly meetings with this as I get status updates, but the plan is to do a mock survey so we can kind of, again, see where we stand, build familiarity with staff, and see what kind of, challenge areas, I like to use that term, that we may have. So then we can put together, just like the Joint Commission would, a report, use a safer matrix as far as where we land on that grid, and then come up with corrective actions so we can work on those deficiencies. And that'll take us right through the spring into the summer. So if they were to surprise us and come a little bit early because it's unannounced, we'll be ready in advance. And so those are some of the things that are coming and some of the things we already have in place. Happy to answer any questions.
Any questions? How many staff do you have working with you on
As
these
far as
activities?
multidisciplinary?
Or staff assigned to you? Just trying to get a sense of your scope.
Sure. So I, as far as direct reports, I have one and she will be joining me when she's available. But I would say that dotted line. So as far as chapter leads, for every chapter, from medication management, infection control, provision of care to nursing, there's what they call a primary and a secondary chapter leader. And so either one of them will be joining, hopefully, that's the plan, and or delegating out to staff members to then join. So we can have, people that are able to go on a unit and spread out focus in all different areas.
Sure.
So we're hitting all the different categories.
And so you're the functional area expert or for this topic.
We're all accountable to Joe.
That's what I'm getting the sense. Yeah.
Just
Right.
gonna say that, we are promoting a culture here where we wanna cascade down the ownership of being
Sure.
survey ready, continuously survey ready to our unit leaders and department leaders.
Yeah, makes
And
sense.
as Craig mentioned, all our facility leadership takes a great deal of importance and attention when we conduct these surveys. I wanna say kudos to Joseph and his one more member team, because until the beginning of 2025, we had outsourced regulatory preparedness to a vendor. We brought all that work in, and Joseph, even though he's very new to the organization, he's been here for less than a year. He has internally absorbed all that work. So we are very happy that he's here, and we are happy that we found great resources and,
Yeah.
assets that we could bring in.
Yeah, it's very impressive, Joe. Yeah, good work.
Again, I'll give credit to the content experts. You know, again,
Yeah.
it's me just trying to manage, orchestrate a process and get everybody together, going in the same direction, so thank you.
Yeah, makes sense. Thank you.
Thank you.
All right, so we're at item, number 5, closed meeting items. So the committee will now go into a closed meeting. Action is not expected to be taken in open session following the discussion in closed session. So at this point, I'm asking for a motion to go into closed meeting, into a closed meeting pursuant to the following exceptions to the Open Meetings Act, 5 ILCS 120/2 C 1, 2, 11, and 17. And as soon as we have a first and second, the secretary will take a roll call vote. So do I have a motion, please?
So moved.
Thank you. Do I have a second?
Second.
Any discussion? Okay, hearing none. All those in favor, say aye.
Aye. Aye.
Oh, I just reminded myself that you had to call. Sorry, Madam Secretary, go ahead.
Roll call vote on the motion to go into closed session, aye or nay. Director Kim? Aye. Director Sorrell is absent. Director Staines is absent. Director Webster Cross?
Aye.
Chair Bott is absent. Acting Chair Garza?
Aye.
You have 3 ayes and 3 absent.
Okay.
Oh, I'm so sorry. I forgot to call Director Masuda Barnett's name in the roll call. I apologize. Aye. Aye. Thank you.
Okay,
I counted you already.
I think we're set. So we'll need a few minutes to clear the room, and then we'll start closed session. Thank you. Have a good weekend, everybody. Thank you.